She will be speaking with us today about her research investigating two human pathogens, Plasmodium falciparum and Epstein-Barr virus, and their contribution to the etiology of endemic Burkitt's lymphoma.
I turn this off now. I want to thank the Center for Global Health for the invitation to come here today. And this picture that I have up here, I'm going to stand over here because it's easier, is sort of your quintessential Africa photograph. And it's one I took on safari at Amboseli National Park, and it's got the elephants there and Mount Kilimanjaro. You can kind of see it in the distance. And so we think about taking a safari, but today we're going to talk about a different type of safari and thinking about looking at cancer in Africa and what we've learned about that, and in particular type of cancer called Burkitt's lymphoma. So when I was a graduate student, my research was on a DNA tumor virus called polyomavirus, a mouse virus that causes cancer in mice, polyoma, many types of tumors. And so I've always been interested in how viruses cause cancer. And I remember distinctly, actually, a person from Yale, George Miller, came and gave a talk when I was a graduate student. And what he talked about was this human virus called Epstein-Barr virus, also known as EBV. And what he talked about was this virus infected everybody in the world. About 95% of the world's population is infected with this virus, but very few people actually develop any problems with it. But in certain areas of the world, there's a cancer link. Cancers are linked to this virus. And in particular, he described one called nasopharyngeal carcinoma, which is an epithelial cancer that's found in Southeast Asia that's linked to EBV. And he also talked about a children's cancer called Burkitt's lymphoma that's found in Sub-Saharan Africa. And I was really interested in this geographic restriction and why that was. I was curious about that. So when I did a postdoc, I chose to work in a lab that worked on EBV. And we did a study on, in a mouse model again, but human viruses in a mouse, human cells, and looked at post-transplant lymphoproliferative disorders. But I really wanted to study Burkitt's lymphoma. So as an assistant professor, I asked everybody in the department that I knew was going off to Africa if they would keep their eyes out for Burkitt's lymphoma. And finally, in 2001, I got an invitation by a colleague who was working on malaria in Kisumu, Kenya. So I always think about that my curiosity brought me to Kenya, thinking about why this virus, EBV, is linked to Burkitt's lymphoma. But it's actually, when we think about it, it's really the children that I saw there and kept me coming back. And all of these are pictures of kids with Burkitt's lymphoma. And when I got there, you see the wards are full of these children. The cancer wards are in very poor shape. There's just was quite a lot of need and still is. And one of the things in thinking about cancer in Africa are some fairly striking numbers. In 2012, over 8 million people died of cancer, but in fact, the majority of those people died of cancer in developing countries. And the frightening number that's coming up is that by 2030, the World Health Organization estimates that 7 out of every 10 cancers will occur in the developing world. The capacity to take care of cancer patients, to understand the needs there, is actually very limited in resource-poor countries. So we have a large public health crisis. So today what I'm going to talk about is focusing on one particular type of cancer and talk about the work in Africa and just briefly put it in the framework of Africa by the numbers, I call it. And then I'm going to talk about the challenges of cancer research in Africa, and then some of my own work both on the etiology of Burkitt's lymphoma, the cancer registry we've been developing in Kisumu, Kenya, and also capacity building as an important part of developing cancer research in Africa. So when we think about Africa, oftentimes people say, oh, you work in Africa as if it's a country, but it is not, as we know. As a continent, the continents of Europe, Asia, and the US would all fit within the continent of Africa. 14% of the world's population is found in Africa. There's 53 different countries. One country, for example, in Kenya, has 43 different languages spoken within the single country there. The average life expectancy is 46 years, but the median age, if you look at that, is 71% are under the age of 25 years. And the cause of death, the primary cause of death is linked, top causes are infectious disease, malaria and HIV being the most prominent, but also lower respiratory tract infections and diarrheal diseases. But when we want to talk today, we want to think about cancer in Africa, which is, again, a little bit of a different story. So if we think about the challenges for cancer research in Africa and what we want to look at, one of the big issues is the awareness that cancer is a problem. As I just said to you, we know that infectious diseases are the major cause of morbidity and mortality in Africa. So people kind of forget, and there's been this sort of long-standing dogma that's fading away, but it's still present that in developing countries, it's infectious diseases. In developed Western countries, non-communicable diseases are the cause of problems, morbidity and mortality. But in fact, that's really, those numbers aren't quite true. And we also think about in indigenous populations, oftentimes there's no word for cancer or understanding of what cancer is. So lack at the community level what cancer is and what needs to be done for that. And we also think about cancer as being a long-standing problem in Africa. It's not something that's just emerging. And I like this picture here as to sort of make my point. This is a West African face mask from circa 1880s. This face mask, in some ways you think it's like Pablo Picasso with a sort of distorted face. But sadly, I think this is a representation. This is a boy with Burkitt's lymphoma that I took in 2007. So I suspect that these face masks might be more representative of cancer that's occurring in the population, not necessarily some other factor. And if we think about challenges, we also have to understand what the burden of disease is, how much cancer is there, right? So if you're not really thinking that cancer is a problem, that's number one. And then if it is a problem, how do you know how much of a problem it is? And that's the second real problem. Lots of problems here. So the way we understand the burden of cancer is through cancer registries. You can have hospital-based registries, which most hospitals in the U.S. have, but those only tell you about people that are coming to that hospital. What we really need are population-based cancer registries that capture the information from across a community and gather information from a number of different resources from the hospital, death registries, pathology labs, cancer clinics, and so on. Typically, a population-based registry has a certain population it's defined, so people within a certain region, and ideally it's between 1 to 2 million people for each registry is a reasonable number to have. Cancer case information that's included in those registries is information about the type of cancer, where the cancer was found, the treatment for the cancer, long-term follow-up, and so on and so forth. And in the era of electronic medical records that we have here in the U.S., this is actually quite easy. Well, not easy, but it's easier data to capture. In developing countries, capturing this information where there's paper records and a variety of disarray. Oftentimes people go to private labs for pathology, so the pathology records aren't in the hospital records and so on. So it's very hard to get that information together. And this just shows you, this is from the International Agency for Research in Cancer, IARC, that's in Lyon, France. And this is the percent of population covered by cancer registries. I think this was in 2012. So in North America, 83% of the population has information related into a cancer registry. So we know very well what the burden of cancer is here, outcomes for cancer, different types of cancer, and this helps with cancer prevention and control efforts as well. However, if you look at Africa, which is, you can't really see on this picture here, but that, trust me, is the continent of Africa, only 1% of the population is covered by cancer registries, 1%. And this is a book that came out in 2012. It's published every few years by the IARC, and it shows that the number of registries that contributed data, there's 4 cancer registries in all of Africa that contributed data for cancer across the world, so very limited information. And all the registries in general, with the exception of Kenya, which I'll talk about, are based in the urban, the capital cities. But in most of Africa, the population lives in rural areas and has different exposures linked to cancer as well that are risk for cancer. So it's really important to try to capture cancer information, not only in the urban centers, but also in rural areas. So another problem is under-resourced clinical research infrastructure. This is a laboratory, the pathology lab at the main national hospital, Kenyatta National Hospital in Nairobi, Kenya. When we got a tour of the pathology labs, you could see tumor specimens just piled up. Very limited training in pathology. There's been some work on that with a good colleague, a friend of mine, Leona Ayers at Ohio State University, has done some work with that through a Sub-Saharan Africa Lymphoma Consortium to try to improve pathology capacity. But in general, there's very limited number of pathologists. In Kisumu, where we work at the main public hospital, there's one pathologist that's there who oftentimes goes for private patients, so he's not there full-time. And so there's very limited access for pathology, and anybody who works on cancer knows that pathology is the key to diagnosis and understanding what types of treatment are needed. So most of the cancer cases are done based on clinical diagnosis, not pathological diagnosis. And if you want to do research on cancer, you really definitely want to have good pathological diagnosis because you want to know exactly what kind of cancer you're studying. So that's a real limitation for doing cancer research. The other thing in terms of under-resourced clinical infrastructure is also thinking about, as I said, the lack of pathologists. We also have few specialized in each of these countries, few specialized oncologists. Nigeria is actually quite high, and Kenya is quite high in South Africa, but in general, the numbers are low. And quite high is really, I could actually probably name all the oncologists that I know in Kenya. And almost all of them are always residing in the capital cities. Very rarely do they go out to the other areas. And the lack of treatment options. This is a diagram from IARC. This is the number of people served by a single radiotherapy center in Africa. There's one radiotherapy that's for 20 to 30 million people. In yellow there, up here you can see greater than 30 million people. There's very, very limited treatment options. Kenya only has one radiotherapy machine in the country. And this picture, this was a story that just came out in the BBC. I don't know if you can see that duct tape there that's up on, that's the radiotherapy machine pulled together by duct tape, and it finally failed. And it's the only radiotherapy machine in Uganda. And the cost of the machine is another $1.8 million, but the country's resources for that kind of money is very limited. So if you think about breast cancer, for example, being treated by radiotherapy, there's no care for that. And then these are just pictures that I took in Kisumu, Kenya, just to illustrate issues when people finally come in for treatment. The wards are very crowded. This is the mother sitting with their children there. There's no place for the moms to sleep. They have to sleep with the babies when they come in. And usually for this type of treatment, they're coming from rural areas, so they stay in for 6 weeks to 2 months. So that's a real problem. This is a picture of a boy sitting there getting his chemotherapy on a hard bench. And as we think about that, we have a beautiful cancer center here, and what we can do here. There's really nothing to provide any comfort to these children as they get their chemotherapy. And then this is a horrible picture, but it's actually not that uncommon, of a child with very advanced Burkitt lymphoma. So oftentimes people go to other types of care before they finally come to the hospital. So treatment is always better with any cancer if you can get it earlier. And a lot of times people come in late with much more advanced disease. And then lastly, the other area that I have a lot of passion for is the lack of training in cancer research and cancer biology in general. When I went to Kenya in Kisumu, all the research focus, anybody was getting any kind of advanced degree, which is very few, was focused on HIV or malaria, not really thinking about cancer as something that needs to be done. So those are some of the examples of thinking about trying to do cancer research in Africa. I once had, I shouldn't tell this story, but somebody who was a famous cancer scientist here saying, "What kind of wine do you have in Africa, in Kenya?" And I said, "Well, actually Gato Negro," which isn't too bad, really. It's $6 a bottle from South Africa. But he's like, I couldn't go to a place without good wine. So it tells you that we enjoy a very privileged environment here where we can do cancer research, where it's easy to get the reagents and the supplies that we need. And we have to plan way in advance to do the work in Kenya so we can get the stuff there. And then if it doesn't work, it's a slow process. But ultimately, I think it's worth it. So what I'm going to do now is talk a little bit about the work I've been doing on Burkitt's lymphoma. And just to give you a little bit of background about this cancer, this is again a girl with a tumor, a jaw tumor. Burkitt's lymphoma is a B-cell lymphoma. It occurs in children between the age of 2 and 16 years, predominantly more in boys than girls, about 2 to 1, male to female, and we don't know why that is. It's got a characteristic oncogene translocation. The c-Myc oncogene is translocated to the immunoglobulin enhancer region, and because of that causes a high level of expression of that c-Myc oncogene and drives the rapid growth of tumors. The Burkitt lymphoma is one of the most rapidly dividing cancers known. And it's extranodal, which is unusual for a lymphoma. They typically can be found in the lymph nodes, but these are actually, the tumors are outside. They can be in the jaw, the retroorbit, abdominal cavities, CNS, and so on. And there's 3 forms, although I'm focusing on the endemic form found in Sub-Saharan Africa. There's also the AIDS and sporadic Burkitt lymphoma, which have mixed correlation with EBV, and I won't be talking about those. I'll be focusing on the etiology of the endemic form. So this is, just to talk about Burkitt's lymphoma, I always like to go back to the beginning and talk about Dennis Burkitt. And I think the story of what he did, I always like this story, so I just have to listen to it. Dennis Burkitt, shown here, he was an Irish surgeon. He was posted down to the Malago Hospital, and that's a picture, that's me there, and Jackson Orm, who's now the head of the Uganda Cancer Institute. They've just built a bigger one. But that's pretty much what the hospital looked like when Dennis Burkitt was there in the 50s, and this was in 2008. Dennis Burkitt went down to Uganda, and he saw these children coming into his clinic with these jaw tumors, right? Very striking. And training in England, he'd never seen anything like this. So he was really curious about what was going on with these jaw tumors. He actually came up, this is a copy of this talk that he gave up in England and talking about the commonest children's cancer in tropical Africa. And so out of that talk, 2 things emerged. One is Dennis Burkitt went on, he did 2 safaris, but one, he wrote for a grant because when he started seeing these kids with this jaw tumor, he wanted to understand, is it just in Uganda? Is it somewhere else? I've never seen it anywhere else. Is this localized to this region? What's going on? And I think I got a grant for about $200. And with that grant, made all these copies and hand drawing of these tumors and sent them around to clinics throughout Africa. And that's this map shown here. And the black dots are the sites where he found cases of cancer. Now, this is not true epidemiology. There's no incidence or any kind of denominator there. But you can see the geographic spread, which is actually pretty striking. Underneath that, though, in red, are the areas where malaria transmission is holoendemic, means it occurs year-round. It's perennial and intense transmission of malaria. And that correlation between the two was really striking. He also noticed when he was first doing the safari, he did another. He's got a great story in Reader's Digest in 1964 called The Tumor Safari. But he got a car and then drove around to all these different clinics to get more information about this cancer. So when he came up to England and gave this talk at that seminar was a young cell biologist named Tony Epstein, now Sir Tony Epstein. And I don't know why he never got the Nobel Prize, but he should have. Anyway, so Tony Epstein was there, and he had an electron microscope in his lab, and so he was looking at things. And in the early 1960s, people knew that viruses could cause tumors in mice and rabbits and chickens, but people said, oh, there was a great debate. There's no way that a virus could cause tumors in people. So Tony Epstein heard about this very unique restriction. It had an infectious kind of feel to it, right? And so what he did was they started a collaboration, and Dennis Burkitt would send up tumor biopsies every once a week up to England from Uganda, which is pretty amazing that they made that transport. And Dennis Burkitt tried to, not Dennis Burkitt, Tony Epstein tried to culture these, look at them underneath the microscope, and it took him a couple of years for things to work. But finally, and what he saw in these cells that he grew in culture, and in fact, one of the other things is, at that time, the only kind of cell lines that people studied were ones that were adherent, so they stuck to the bottom of the flask. And so he had all these cells that were floaters, we call them, and he was throwing them out and realized eventually, as he said, he's throwing out the baby with the bathwater because those floaters were the lymphocytes, and they don't adhere. And so he'd thrown these cells away, but eventually one day he realized maybe he should look at those. And he saw these classics. This is a herpes virus. This is Epstein-Barr virus now. And it's very striking morphology that he described. So it's the first virus actually identified by discovered by electron microscopy. So everybody was really excited about this. This is great. There's this virus in the tumor. But then what they discovered, unfortunately, is when they started looking and they made a serology test, is that everybody in the world is infected with this virus. And like, oh, so much for that theory. So they had to go back and rethink this. So as I said, 95% of the population worldwide are seropositive for EBV infection. People get it. It's transmitted through the saliva. I'm going to tell you, give you some data today to say it's also transmitted another way. But generally, it's found in children, sort of the early age of saliva transmission and sharing. And then it doesn't come back up until later in life when people start exchanging saliva again. It used to be known as the kissing disease. And it's linked to a disease called infectious mononucleosis, which is a self-limiting disease that occurs in teenagers and young adults when they get the primary infection. But that doesn't really cause a problem. However, it's now listed as a class 1 pathogen by a class 1 carcinogen by the World Health Organization. It causes approximately 200,000 cancers per year, every year. So it's a huge cause of cancer. So it's one of those things that might be a rare event, but when everybody's infected with the virus, that's what's going on. So I want to talk just a little bit about malaria, because as I told you, as you saw that red shading in the map, malaria is the other pathogen that plays a major role in Burkitt's lymphoma. So malaria is transmitted by a mosquito, the Anopheles version of mosquito, strain, species, I think. There we go. And it goes and gets into the liver. From the liver, it sets up shop there for about 9 or 10 days. You're not really sick, and then it goes from the liver and emerges out into the red blood cells and infects the red blood cells in these different types of forms that are easily diagnosed actually by microscopy. And then eventually it forms this sexual stage, the gametocytes that are taken up by the mosquito, and repeats the life cycle again. So there's actually 5 species of malaria. The species that's most common in Africa is the Plasmodium falciparum. This is the one that's associated with the most morbidity and mortality because it infects those red blood cells at a high level and causes serious loss, anemia, and also cerebral malaria. I actually should adjust this. With the last 10 years, there's been a lot of interventions of introduction of bed nets. And 5 years ago, this number was true. It's actually, they think, it's about 650,000. So there's been some significant reduction in deaths in children in Sub-Saharan Africa. The interesting thing about malaria, and the falciparum malaria in particular, is that the immunity you eventually develop immunity to disease. You don't have immunity to infection, so you can get repeatedly infected with this parasite. So that's another key feature of this. It's not like when you get your measles vaccine and that's it, you're protected for life, or you get measles infection, you're protected for life. When you get malaria, you get malaria, you get malaria. So you repeatedly get this infection. And if you survive childhood, you're immune to disease. If you move away from this area, you'll also become susceptible again. And that's a study, a whole other set of work to do. But oftentimes what malariologists talk about is thinking about the transmission. This is really a focus on that because there's different areas that have different malaria transmission intensity. And as I said, the areas where it was red, it's holoendemic, which means that the mosquito can live. These are places on the equator. The mosquito can survive year-round. The malaria parasite is transmitted year-round. In Kenya and other places, we have highland malaria, where it's more epidemic, where the mosquitoes, the temperature changes and fluctuates enough so that the mosquitoes are only come out and are able to transmit in epidemic. Oops. But what I like to think about this in terms of thinking about the etiology of this cancer, the cancer, is that malaria can be considered to be a chronic infection of these children, right? So it's not an acute infection, it's chronic. EBV, once you've got this virus, you have it for life, so it's a persistent infection. So you have this chronic reinfection with a virus that persists in you. So the work we've been doing is in Kenya. It's in East Africa, shown here. We work in Kisumu, right on the shores of Lake Victoria. Lake Victoria, just for a framework, is the second largest body of fresh water in the world. The first is Lake Superior, one of our Great Lakes. So it's a very large body of water. And as I said, it has well-defined and different patterns of malaria transmission. So it allows us to do some research where we can see people with and without malaria. But everybody gets EBV, so that adds a nice control. Although I talked about clinical infrastructure for cancer research isn't available, in Kisumu, Kenya, we work with the Kenya Medical Research Institute. There's a research station that we work at. And so reasonable amount of infrastructure. We have a qPCR machine, BSL-2 hoods, centrifuges, pretty much everything we need to do there. And we have access to the clinically relevant populations. And I just wanted to have some pictures of Kisumu. Sometimes people say, oh, you're working in Africa. Are there lions where you're staying? And the answer is, of course, no. That's where the view from the hotel where I have my gin and tonic at night. So much nicer than lions. And Kisumu town is there. So it's the third largest city in Kenya. This picture is at our clinic that we work at in Challe, Kenya. This is a little baby getting weighed. It's one of our, they have a maternity health clinic there, maternity child health clinic. And then this is, I really like this picture. This is David Madem, who's our clinical officer, and he's just a lovely man, and that's, you can just tell the way he's touching the mom and the baby there. He's really quite good. Outside the clinic, out on the road, this is a traditional homestead that you'll see there. They've actually switching away from thatched roofs to having metal roofs now. That's the view from the car. Oftentimes the roads are not in the best shapes. These are the tea plantations up in the highlands of Kenya, and then just a traditional shop. So when I first started working there, we had some data from a colleague, Dr. Walter Mwanda, who had collected cases of Burkitt lymphoma. He'd sent out medical students that had come to train at Kenyatta, and he said, when you go back home, go to the hospital and see what hospital-based Burkitt lymphoma cases you can capture. So the cases are not exactly the best, but what we did is took that data, and I had a graduate student, Jeanette, who then mapped the cases of Burkitt lymphoma, which is shown here in the darker is the higher incident rate. This is the coast of Kenya right here in the Indian Ocean. This is Lake Victoria and Kisumu right there. And what you'll see is that when we map it by malaria endemicity, they actually map very well. And if you do the statistical analysis, malaria and Burkitt lymphoma incidence correlate. So more malaria, more Burkitt lymphoma. And this also allowed us to map out different regions in our population where we could study those that had high levels or low levels of malaria. So one of the first things we did was just do a cross-sectional survey and look at EBV viral load. I told you the virus persists in the peripheral blood. You can pull out a small amount of blood sample, just 100 microliters is all you need. Do a DNA extraction and do PCR to measure the amount of DNA in the blood. It's typically the DNA that's in the cells, in the blood, the B cells. And this just shows you, this is a log scale, just to note that. These are U.S. adults, Kenyan adults, children from the highlands, children from the lowlands. Nandi kids are very little malaria. Kisumu kids have a lot of malaria, and then these are BL patients. And you can see this trend towards increasing incidence. I just like to point this out. In the U.S., if I was trying to do PCR, if I took a PCR sample from anybody here, even though you're EBV positive, the amount of virus that you have, the B cells that are infected, is actually very, very low. In the Kenyan adults, it's about 30% easily, readily detectable, and then in the kids, it's about 60 to 70%. I had hoped when we originally did this data that I'd see some differences between the people in the highlands and the lowlands, which we didn't, but then we broke it down by age. And what you'll see is in the 1 to 4-year-olds, there's actually almost 3 log scale difference in the viral load. So the kids in Kisumu, where there's more malaria, had quite a bit of virus in the blood compared to the kids in Nandi, where there's very little malaria. And when you're looking at that 1 to 4-year-old, that means you have to look earlier. So we did 2 prospective cohort studies. The first one, which I'm going to talk about the data second, because we actually ended up keep on going backwards, we sort of to birth. We did the first study, we compared Kisumu to Nandi children and followed the children from 1 month through 3 years of age. I'll talk about that data second. And then the study we're just completing right now is a study based only in Kisumu, where we followed mothers through the antenatal clinic and looked at their malaria exposure, and then through delivery and followed up those kids after that. And the question we wanted to think about, if it's in the 1 to 4-year-olds, what's going on with those kids? So you can't quite see that well, but we've actually now enrolled 370 mothers, but this is the initial study. I had 2 PhD students. We didn't want to wait 5 years for their PhD. So we did the study with the first 200. There was 175 HIV-negative mothers. In this study site, we have what's called an AMPATH clinic. This is through Indiana University in the PATH and provides care for HIV-infected populations. What I'll just note here, 25 of these moms, this was the first time diagnosis with HIV. A very high prevalence in Kisumu, Kenya of HIV infection. And we looked at, and we had these mothers come in at the antenatal clinics, and they came in 4 different times, up to 4 different times, and then at delivery. And we measured the amount of malaria in the blood. Now, these moms are getting treatment for malaria during pregnancy. It's called an intermittent IPTP, intermittent prevention for treatment prophylaxis. They're trying to reduce the amount of malaria during pregnancy. So the mothers were getting that, and they're not these 54% that were Plasmodium falciparum positive during pregnancy had no fever and didn't have detectable by microscopy parasites, but they did it by qPCR. So we had actually a roughly equal amount, 54% versus 46%. At enrollment, 64% of the women with a malaria parasite DNA also had EBV DNA detected compared to 36% of the women without malaria. And the EBV load in the women that were malaria infected during pregnancy was much higher, so they carried a higher burden of malaria. And there was a significant positive association with that. And it says to us that malaria is actually inducing EBV reactivation, and this is something we know from our other studies. So you're pregnant, you get malaria, and you have EBV, but the EBV now it goes from being quiet to becoming an active infection. The other thing is we then wanted to say, okay, this is during pregnancy. What happens when we look at delivery? So we looked at, you get transplacental transfer of IgG antibodies from mom to baby to protect those babies against infection. Very important thing in biology. And when we looked at this was data done by my student Sydney, we actually saw that the mothers that had malaria during pregnancy had a reduced amount of EBV antibodies that were transferred for them. And you can do this, you can look in the cord blood of the infants and see what's in the cord blood. This is what comes from the mom, and then also we looked at the mom. And then we also looked at immune function by flow cytometry, and this was actually done in Kenya. So this is a flow cytometry chart just showing, trying to look at the different cell populations that are in that cord blood. And one of the cell populations people have talked about is what's called a regulatory T cell. This is a T cell that can become immunosuppressive. Typically, it shouldn't be there. Healthy kids with no infectious disposure shouldn't have it. But what you can see is that there's actually a striking increase of Tregs in these kids that were born to moms with malaria compared to the other ones. So these kids, so again, this malaria-EBV interaction, there's a lot going on in malaria and immune interaction. And then we wanted to look at the moms to say, well, if the virus is reactivated and the babies, we know that EBV is transmitted through the saliva. We asked the question, could it be transmitted through breast milk? Because the babies are breastfed for quite a bit of time. So it's my student Ibrahim did this study where he looked at EBV prevalence and then the load over visits in weeks postpartum, 6, 10, 14, and 18 weeks. So we just took the breast milk samples and measured EBV by qPCR. And then he also went back and analyzed this action with our biostatistician. And there was higher viral loads in the breast milk of mothers who were malaria positive. So malaria is reactivating EBV during pregnancy and also causing shedding of the virus. What we wanted to prove, though, and this is work done both by Ibrahim and then this is actually by Carrie Coleman, who's here with me now. We looked and wanted to see if the virus was actually infectious. Because you might be picking up viral DNA, you just don't know if it's going to make anything happen. But what we found was that if you add the virus, the breast milk, to cells, you can show that the virus is actually infectious in the breast milk. So then we want to look at the kids. So this is my first study, which, like I say, doing it backwards, but age-wise it makes more sense. When we look and compare the kids and ask what age are they infected with EBV, when do they get the infection with EBV, and we look at the Kisumu kids versus the Nandi. So Kisumu was more malaria, Nandi's Highland, very little malaria. There's actually, the kids in Kisumu are actually significantly infected at a much earlier age. And in fact, up to 36% of them are infected before 6 months of age. Quite a striking number of kids infected very early in life. And then we followed these kids up to look at their malaria exposure and their EBV loads over time. And we've done been collaborating with a group doing math modeling. I'm going to show you not the quite math modeling data, but pretty cool anyhow. But what we found is we looked at that data over time and looked at EBV area under the curve analysis. And the kids that were infected with EBV either earlier in life or had malaria or both had more EBV viral load over time. So they amplified the viral DNA more rapidly and there was more virus. So they didn't have a good control of that infection, which links back to those regulatory T cells that are there that shouldn't be there. So malaria is doing a lot of different things here. And I like to throw this slide up here because when we talk about it, and if there's any pediatricians in the audience, you might think about EBV infection very differently than what we typically think. Most of the studies, this is a US study, this is infants born to HIV positive or HIV negative moms. At 24 months of age, it's about 55% of the babies are EBV positive. A study done in Hong Kong, urban population, a little bit earlier, somewhere about 20 months. And then this is a study done in the 70s in Ghana, and that's about, at 1 year of age, 50%. And our data is strikingly earlier, even for both the kids in the Nandi Highlands. And one of the things that all these other studies have done is focused on urban populations, which is a different group. Ours is on a rural population as well. So anyway, we see much earlier age of infection. It changes how we think about this virus. So when I first started to work on and had that kind of question about what happens, why do we have EBV and malaria, what's going on with these? The original ideas were that malaria is suppressing T cell responses, activating B cells, so much more immunologic. And my studies have led me to think about malaria as a sort of a continuum across life in terms of the effects it has on the babies. What we see is that malaria affects during the pregnancy, so it reactivates the virus during pregnancy, so you get that reactivation, causes the mothers to reduce transplacental transfer, shedding the virus in the breast milk. When the baby then gets exposed to malaria, and they're infected earlier in life, they have poor control of the virus that causes reactivation of the virus, higher viral load. What I'm not going to talk about is the last step is why does that link to to Burkitt's lymphoma? We have some data from our study that we did that shows that kids with higher EBV loads have elevated expression of an enzyme called activation-induced deaminase. This is an enzyme that's been shown to be in mouse models linked to the c-Myc translocation. And remember, I told you Burkitt's lymphoma has this classic, all BL tumors have the c-Myc translocation that's important for tumorigenesis. And this enzyme is linked to that. We haven't proven the two steps because it's very difficult to do because it's even though it's a very common cancer, it's about 1 in 10,000 children incidence, so it would be hard for us to do that. But we're working on some, our next sort of projects are trying to look at this more in the laboratory side of things to see if we can prove that the malaria-induced AID is linked to that c-Myc translocation. When we think about future directions, there's a number of things. I was actually really disappointed with our data because there's a push to develop an EBV vaccine that would prevent EBV infection, but when you're infected so early in life in these rural populations, there's no way we're going to be able to have a vaccine that would work in that. But I've been talking to a group that's looking at a therapeutic EBV vaccine that would target people that already have the cancer and get their immune system to recognize that cancer and see that, and so hopefully we'll be able to go in that direction. Are there any questions about this? Not yet. So the NPC, the nasopharyngeal carcinoma that's found in China, and actually I should just say it turns out it's also found in Kenya as well. But we have to track down a little bit more of the incidence, and it's found in the highlands of Kenya, not in the lowlands where Burkitt lymphoma is. I think that there's more EBV-associated cancers just because this virus is, it's poor control in general in that population. But we haven't looked at sort of risk further on. It would be hard to do that, but I'd like to. I think that would be, I would love to try to do that. So that would be the other piece, but there's a bit of data that I didn't mention, that the EBV vaccine targets this glycoprotein called GP350, or it's a GP350 base, so it would induce antibodies against that. What we're working on, and my student Nick is looking at, is there's 2 strains of EBV, and the second strain that's common in Kenya might use a different receptor and it infects T cells. So that won't work either, I think. We have to sort of think a little bit. But I thought about that as an alternative strategy to boost their antibody responses so that then they would have more antibodies to transfer and protect. Anybody else? So in the last few minutes, I'm just going to talk about the work that we've been doing with the cancer registry. So Kenya is really sort of leading Africa in terms of cancer awareness and having government input. There's only one other country, Tanzania, that has anything related to a cancer institute, and it's not a national cancer institute. So they've come out with a cancer control strategy that's trying to really address this problem. And this, in February 2015, they launched the National Cancer Institute, which sounds great. And the US NCI is also working directly with Kenya, and I've been working with some of the people there as well to try to see what we can do about improving cancer care and control and prevention in Kenya. However, resources are limited, and that's the real challenge. But what we started doing is looking at cancer registry, and as I told you, nationally, across Africa, most of the registries, the 26 are there, so half the countries now have registries of some sort, and they're usually based in the capital city. Kenya has the Nairobi Cancer Registry, was started in 2001. There's an Eldoret registry up in the highlands of Kenya that was started about that same time. And then in 2010, we started the Kisumu Cancer Registry on the shores of Lake Victoria. So Kenya, and there's 2 more slated to occur, one in Mombasa, which is along the coastal region, and then one over in this middle section. So that we'll try to have within Kenya something equivalent to what we have in the US, where we have a broader sense of cancer data. This is just a picture. Actually, one of my favorite places to go in Kenya is Tilapia Beach and have beautiful, yummy fried tilapia. This is Anne Carrere, who I think with any of these efforts, she's the person who's been really driving the cancer registry efforts in Kenya. She's just an amazing woman, working on her PhD now. And this is John Oyambi and Carolyn Omanji, who are my 2 cancer registrars, who are there sort of the ones that tirelessly go to all these different places to try to get all this information for the cancer registry, where the medical records are in very poor shape. But they're really doing a great job. And just to point out, this is Max Parkin, who runs the Africa Cancer Registry Network, and Brenda Edwards. They were there sort of on a site visit to assess our cancer registry, and we're not quite ready for international partnership, but we're getting close. But I wanted to share with you some data that we've generated. This is data from 2011 to 2014, the top 10 male cancers. And what you'll see is the #1 cancer in this region is Kaposi sarcoma. So this is an infectious link to Kaposi sarcoma, herpes virus. The #2 cancer is esophageal cancer, and then non-Hodgkin's lymphoma is down here as the #4 cancer in males. In women, the #1 cancer is cervical cancer. So again, an infectious-related cancer. Typically, we think about the infectious etiology of cancer as about 20%. I suspect in Africa it's much higher as a percentage of total cancer burden. The second cancer here is also esophageal cancer, and that's very unusual. Esophageal cancer is typically more common in males than females. Here, it's equally common in male and female. Smoking is thought to be a cause of esophageal cancer, but in this population, there's very little smoking. And what you'll notice on both of these sites, there's no lung cancer there. It's not on the charts. There's not smoking. There is a little bit, but there's just not enough money for cigarettes. And Kenya actually instituted a policy to prevent cigarette smoking in public places 3 years ago. So they're very much ahead of the curve on tobacco control. And I just want to show this slide. This is from WHO. This is the 2012 top male cancers worldwide. And there you'll see the lung cancer is really the #1 cause of cancer worldwide. The #1 cancer, prostate, colorectal, stomach, and so on. In KS, this is actually, there's a lot of other cancers. This is number 27 or 28 in terms of common cancer. And then just to show that comparison between what you see in Kenya. And it's a very different pattern that you see. And it really highlights why we need to have cancer registry efforts within country and actually within a region within a country. And then lastly, I just want to talk about cancer research capacity. In 2011, we had a D43, which is through NIH for building cancer research capacity for AIDS malignancies. And I worked with an oncologist, Scott Remick, and a pathologist, Leona Ayers, to initiate this. And the idea would be to start clinical trials linked to the AIDS Malignancy Consortium. And we launched that training grant. And I just wanted to point out, this is my student, Sidney Ogola, who just got his PhD yesterday, so I was very excited. And he'll be coming here to do a postdoc. And Ibrahim got his PhD with me. Odata got his PhD. He's now our project leader in Kenya. Amolo Asito got his master's, his PhD, and his postdoc with me. There's not a lot of choices there. So, and he's now head of his division at Bondo University as a equivalent to a chair. She's finished her PhD in Italy. She's a pathologist, Elena Rogena. These are two physicians who've learned clinical trial work. And this is Walter Mwanda, an oncologist in Nairobi, Scott Remick, and Leona. So I feel like over the years since I've been there, when I got to Kenya, there was 2 PhDs that worked at the Kenya Medical Research Institute at our site, maybe 3. But they all worked on malaria or entomology. And since we've been there, we've actually trained a number of students and have a great interest in cancer research there, which is, I think, really terrific. So I'll just stop by asking the question, why do cancer research in Africa? It's definitely not for the fine minds. But what we think about is that Guy Dete, who worked on Burkitt's lymphoma and did some beautiful studies in Uganda in the 70s, called Burkitt lymphoma the Rosetta Stone of malignancies. So it was the first human cancer shown to have a human oncogene. So the CMIC was the first time that they found that. They'd found the oncogenes in mouse, but not in people. It's the first one found to be treated only with chemotherapy. And part of that is that they had as you saw, the radiotherapy machine didn't come until 1995, so they had to come up with creative ways in the late 50s and 60s to treat this cancer, and they showed that they could cure it with chemotherapy alone. The first human cancer is shown to have a viral association. So I think there's a lot we can learn from studying cancer in Africa. I think there's a lot more to be discovered. But I also think the reason to study cancer in Africa is the kids with cancer. And these are, my husband has Maui gyms, and so the kids were putting the glasses on and having a great giggle at their pictures. The cost of those sunglasses is the same cost of chemotherapy for each of those kids. And so you think about just how we look at cost and what we need to do. It's not that much, but there's more to do. So I'll just thank the 2 groups here, my team in Kenya. That's Carrie, who's here with me now, who moved with me from upstate, and Nick Smith. And then Will Eaton also, who went to Kenya this summer and did some work with us. And I think I'll just, take any questions. That's Africa, too. Thank you. We try to, so that's why we're not, we can't get into the Cancer in Africa book. So it's morphologically verified diagnosis has to be, and that would be through pathology, it has to be greater than 50%, and we're about 30%. So our data can't be given to the WHO because we just can't get that data. And there's not much we can do about that. It is a big challenge. I often think what I wish we could do, You know, in Africa, they leapfrog past landlines for and switch to cell phones. And even banking, they've used their cell phone for banking. And I keep on thinking, can we leapfrog past pathologists? Not that any diss against pathologists, but it's just the training is so long. Is there ways we can diagnose tumors more rapidly with quicker tests than requiring a pathologist to verify them so that we could actually get more accurate diagnosis? Challenge for the young people in the audience. All right, well, thank you very much.